information to all of you, which we've done quite a bit within ECHO, by sending you articles, as is the case today, and definitely with the article that we're going to talk about on collaborative care sort of later on in this presentation. But I did want to take some time at the beginning, sort of like maybe the first half or maybe the first 40% of this presentation, to talk about ways that basically, I know that the majority of people on this call are caregivers, not necessarily people engaging with research. You know, we have presentations from certain researchers here at Neomed who talk glowingly about spending each morning looking up PubMed for hours at a time. And I realize that that's a privilege that not everyone's job allows. But I do want to point to some potential ways to allow you to, I guess, feel empowered to explore the literature, but also based off of really some discussion that happened organically, I think a couple months ago, where one of the participants was asking, you know, how can we assess what we find? You know, full disclosure, I'm a medical librarian. That does not mean that I am an expert at evaluating whether it's the statistics or the clinical evidence. I realize that all of you are more credentialed in that area. You know, I can provide expertise when it comes to probably the search methodology for a systematic review, but I can also provide expertise in what I'm going to talk about today, which is why it's called How to Stay Current with Best Practices, tracking down the latest literature. It should really also mention like how to keep track of what you find and where you find it, because I do want to emphasize a few points today that really gets to the, I guess, the core of thinking about okay, you might be finding stuff, whether it's via Google or via your medical library here. How do you know whether or not you should trust it? And that's sort of an ongoing debate that is yet to be decided, but it's important to mention. And before I mention this as well, I do want to just sort of make a point to emphasize that really everything has been affected by COVID, but this too has been affected by COVID, which I'll get into later. I mean, there is such a rapid flow of publications that are coming out, and they reach all the way up to the White House, and they are often used incorrectly. And I know that you as caregivers are not going to use the same degree of information incorrectly, but I still think it's worth sort of diving into some examples of like why the information from different sources is being used, even though it's all found through, say, Google or Google Scholar or even PubMed. Okay, so I know I probably just mentioned a few of these, but definitely I think the no-brainer is, you know, it makes sense to stay current with the recent literature. We realize that, and we also know that, as I was mentioning, it's a time suck. So I do want to talk, as I mentioned, the obstacles and opportunities for attaining this info, the spoon-fed, as I mentioned, which we'll get to later, versus the searching empowerment on your own. Evaluating the literature, I spoke to that. Thinking critically when it comes to, so this is the specifics of what I'm going to talk about. So the dissemination of scholarship, whether it's a different type of publication, and I'll define these in a bit, but thinking about different modes. Feel free to let me know if this gets too jargony, but thinking about like preprints, author accepted manuscripts, those are typically open access publications, and then final journal articles. Sort of think about those different forms and the reliability of them. Thinking again about where you access research from. We'll also just make a brief mention of thinking about systematic reviews and the concept of research waste. And then things will be handed over to Nicole to talk about one of those articles, which we sent all of you out of that broader list that we've been pulling. So I won't dwell on this too much because I think I've already maybe highlighted a few. But I think the big thing to take out of this slide is I realize that a lot of participants are going to fall into two broad categories. Those who are clinical faculty affiliated with Neomed or potentially like a large hospital that might have its own medical library, and those who don't. And I think it's worth emphasizing here that a lot of that is governed by copyright, and a lot of that creates basically a hub, right? We're a medical library here that spends, at a deeply discounted rate, we spend upwards of, you know, over $500,000 a year just to provide access to, I mean, a lot of information, but we could be spending a lot more to provide basically what's really expensive literature. I think there's probably a common misconception. I've heard faculty members mention if they had $100,000, they could build the best library, and it's that's just not true. The publishers are very good at licensing information in a very expensive way for all of us, and that information is very valuable. And so it creates this great privilege, and these are why programs like ECHO and the centers such as the Best Center definitely disseminate these research articles through copyright allowances. But there's also times where you can look in other areas to be able to get a hold of the recent literature, the latest evidence, and that's sort of a shifting paradigm, if you will, that again sort of has been affected by COVID. Like, just to, as a quick example, I mean, you guys have maybe noticed this, but all COVID research has been made freely available. It's all green, open access. You'll see the green bubbles. That's not always the case. That's going to be scaled back, but the publishers at the get-go said, we're going to make all of this research freely available, which is a good thing. We wish everything was that way, but unfortunately it isn't. So this is just to emphasize, like Neomed, what I was mentioning, the big point, and this is what I like to tell researchers, students, and faculty, we are infrastructure that is mostly digital now. You don't have to come to us. We make sure it reaches you. Digital resources are the ones that we buy primarily, and you can access them really throughout anywhere that you have an internet connection. And you'll probably notice, like, we provide the search boxes, et cetera. And these were the things I was mentioning. Not everyone has access. So even still, if you don't have access, I will get to those additional forms, and I'm going to dwell, rather quickly on the additional forms of access that are available. You can still keep in mind, this really gets to the question that was raised, like thinking about certain factors to keep in mind, whether you belong to the research university or whether you belong to a private practice that doesn't provide any access to any of these paid subscriptions. Nicole and I did want to mention, avoid just looking in a single space, whether that's Google Scholar or PubMed. Just looking in one space can do you a disservice because there are certain publications that are indexed via each one. Take advantage if you have the opportunity of the expensive resources that are available to you, whether that, again, that's the case in point being university. If anybody knows that they're a clinical faculty and wants to get access to these resources after this session, please feel free to reach out. So here's if you don't have access, there are forms of information, as I was just mentioning with the COVID, open access, and then one that we're going to dwell on today, which is preprints. Which quickly defined is, instead of the article being peer reviewed and published, which, as you know, can be a lengthy process, over the past 20 years, there's been an increased desire among certain researchers, usually out of top institutions who are conducting research, to deposit their research into what are known as preprint servers. This started early on with the mathematics and chemistry community, but it has now spread to medicine, which I'll get into in a second. And I did just want to mention this because it's worth considering that peer-reviewed resources are not infallible. There are issues and there are biases that will go into those resources. And I know that this is kind of the controversial topic within academia when you talk to a bunch of researchers and you start to suggest that potentially moving away from peer review would be a good thing. I don't agree with that, but there are discussions about the limitations of peer review and how having what are known as preprint servers can be a better alternative to allow for really what this quote here is emphasizing, thinking about academia being overwhelmingly white, with shrinking numbers of women and people of color, and the publishing industry being the same way, with those inherent biases that have been sustained over sometimes centuries. What I'm going to mention here, and these again are freely available resources, is a mode to allow for dialogue around scholarship and a way to engage with scholarship for certain voices that might not have been allowed to engage in that dialogue and still aren't allowed to engage in that dialogue. So before I quickly go over preprint servers, in case you aren't already aware of it, just always make sure that you're looking for things like conflict of interest, retractions with articles. That will happen. It happens in the most prestigious journals, and it happens in the least prestigious journals, and it also happens in journals that are known as predatory journals, which are journals that are kind of just, I guess, sham operations that are trying to fraud academics into publishing their content. And that's a topic that I could go into for far greater length than I have time right now. But if you haven't already heard of this, there are occasions where these operations that look legitimate are not in fact legitimate. And there are lists and watchdogs basically that keep track of the specific articles. And those, it's worth mentioning, they get indexed by PubMed, but they also, on very rare occasions, but they also get indexed by Google Scholar. So there can be issues with where you're accessing your information. And I've already mentioned this, don't just trust the high impact journals because they're high impact. There can be low quality research there with certain biases, and look elsewhere. So I've already mentioned this, I sort of jumped the gun here, but PubMed has predatory content, so I won't dwell on this. Beall's list is an important resource that got taken down, but there's what's known as like the whitelist. There are ways to track whether or not something is a predatory journal. Reproducibility is another big topic to constantly ask, whether it's a systematic review or any sort of research article that analyzes data. Is it reproducible? Can you ascertain whether or not the data was hacked to meet the desirable outcome, concept known as p-hacking. And systematic reviews and meta-analyses, I'll mention that briefly at the end, but it's a big topic. It's a big problem. So this is just an example of people looking into, even reliable resources such as PubMed will have predatory content, which is usually synonymous with research, like garbage research. Okay, so just quickly, I just wanted to mention, and I know I tend to talk a lot, so I know I've probably already talked too much, but I am gonna briefly go over these different types of research. So I'm hoping everybody's familiar with peer review and the end product, like the article we sent you out. That is available, usually behind a paid server, or it's an open access form of content. As I was mentioning before, preprints are essentially a public draft of a manuscript before publication. It's an author accepted manuscript. The author accepted manuscript would be a peer reviewed version of an article with less polish than the final publication. And then the final journal article is what's peer reviewed. So here's an example of a resource that probably you might not have heard of. It does not get indexed by PubMed, but it's an example of a preprint server where you could do research on a variety of topics. It's very popular at the moment because of COVID research. So researchers are constantly workshopping their ideas. The big thing to mention is that researchers can get their article, it's still vetted by a team, but it usually gets vetted within 24 hours. So it's not peer reviewed, but it is done by leading academics as a way to put their work up before it's been peer reviewed and get it to be workshopped and criticized if necessary. So it's kind of a radical take on a very traditional form of scholarly publication. But I do know, based on attending conferences recently, like this is, I think right here, the fact that NIH has all of a sudden decided the National Library of Medicine is going to create a preprint server is a very big leap, and that's because of COVID. So if you haven't heard of these already, I encourage it, especially for certain topics, like whether it's medical marijuana or the opioid pandemic. There's going to be a lot of interest in putting out this research as quickly as possible. So this just brings up a couple more points. It's fast versus thorough. It does expand diversity of individuals who can critique the research in progress. As I mentioned before, the biases. 70 to 80%, they end up in journals. It expands readership and it expands impact. So you as the caregiver can, in theory, access this research for free, examine it. There is the caveat that this should not be utilized as a direct way to influence your practice. It should be scrutinized and thought about critically. And we've sort of seen this in real time. I don't know if anybody saw this a few weeks ago, but it sort of sent shockwaves around the world. This is an example of a preprint about plasma for hospitalized patients with COVID-19. Sort of the president and his administration jumped on this one piece of evidence. So it really does not reflect the best practices, which is to look at as much evidence as possible. And instead it was just one that was used incorrectly and sort of has huge liability. So that was one example of a way to access more recent research and also to think critically. Now we're going to talk about what we sent all of you in this past week. So you guys should have gotten a list, I believe, but also the specific article that now Nicole is going to talk about. And this represents the peer-reviewed literature, which we do feel can inform your practice, but also should be thought about critically. So this is just something I mentioned before, which is we search in multiple spaces. So now I'm going to hand it over to Nicole to talk about the article that you all read.
Yeah, so the article, which you could see the citation up at the top, Achieving Mental Health Equity, Collaborative Care, what it did is it looked at how collaborative care can potentially be used as a way to reduce health disparities for marginalized populations. We know that it is really a more systems-based approach. So collaborative care being that integrated care model that you typically see in a primary care setting, where it's team-based collaboration between the primary care team and mental health clinicians. In traditional collaborative care, that means a behavioral health person, counselor, social worker, marriage, family therapist type would be embedded within the primary care practice. And then they have a collaborating psychiatrist that also reviews charts, meets with that behavioral health person, and occasionally will either make recommendations to treatment, or if a person gets to a point of care that they are in need of a higher level, then they might even see that individual themselves. So when the article looked at a bunch of different studies that have looked at collaborative care and tried to piece out those ones that figured out if it was helpful with marginalized populations, what it showed was that in usual care, ethnic and racial minorities have lower engagement in what would be considered usual care. So that being, a primary care physician may be saying, okay, you seem to have some depression. Here's a card for somebody that you could reach out to. We recommend counseling. And then not really doing anything to connect. Minorities tend to have lower engagement and they have worse PHQ-9 scores, so showing a higher risk factors of depression and potential suicidality. But with collaborative care, a number of the studies showed that both Black and Latinx populations had significantly greater improvements in their mental health outcomes compared to white populations. There was increased rates of initiation of treatment, both with the behavioral health counseling portions and medications, improved physical, mental, and quality of life outcomes, lower depression rates, and they looked at this longitudinally, and even at 10 years, there were still significant improvements in mental health outcomes. Next slide. So it has been shown to improve engagement and access to care, and also improve the quality of care when it is received and the health outcomes, particularly when you look at culturally centered care. So culturally centered care being able to provide a bilingual provider, which shows an even greater reduction in health disparities and more patients accessing their preferred treatments. When it's a culturally centered collaborative care, there's higher patient ratings for their perception of the care overall and perception of case management compared to all other depression improvements. And a recent analysis of policy to address mental health equity recommends that beyond the clinical care goal, that we really need to be explicit about considering both racial and ethnic discrimination and attention to specific issues that are underlying social determinants of health and social determinants of inequity. Next slide. Adding social care to collaborative care, in addition to that culturally centered piece, shows even better reduction in health disparities. So that when they looked at a disaster scenario using collaborative care post Hurricane Katrina, collaborative care was expanded to include services that actually address some of the social determinants of health. So actually being able to address financial issues, all of the possible things that you would imagine following such a massive event. And when adding those things in, you further see the reduction in health disparities and people their mental health and general quality of life improves holistically. When they've looked at populations, more specific populations, so male veterans, and they added collaborative care plus some technology, so telehealth, various apps, and that was able to show a greater depression outcomes for Black male veterans and compared to white male veterans, which really speaks to some of the engagement piece. So we're having to need to engage people a little bit differently. Traditional mental health and traditional primary care maybe has not done a great job at helping address health equity and helping address mental health for marginalized populations, populations of color. And it does look like maybe collaborative care can be part of that solution. And yeah, that was all 3 of my slides. So that's the stuff that I'm interested in talking about with all of you, but I'll hand it back over to Simon.
And yeah, so great, and we'll open it up for discussion in just a sec. I think the one final thing worth mentioning is sort of the methodology side of things here. It's a quote unquote rapid review, which is a very vague way of saying that they've looked at a lot of literature in a rapid way, and which would be different than, say, a systematic review, which in theory, at least, the systematic review is supposed to have a reproducible search methodology, which is not always followed, but there are specific protocol, as you might know. So that's just another example of thinking. I thought this article was good because it did identify that a limitation is that it was a rapid review, not a systematic review. So there potentially could be more literature out there that they just did not locate, but it still is a great primer because it is looking at a broad set of publications. So, so now is really the time for discussion and conclusions. I guess this will be the concluding moment. We were hoping to just have a free forum, a dialogue. That's why we sent out the article before. We can also have a dialogue around any of the other stuff I mentioned, but definitely, since this is more of a journal club, we want to have a discussion around that specific article. So this is where I hand it over to all of you.